Again, we'll, can everybody hear me okay? Yeah, okay.
Yes.
So welcome to our ongoing global health series, research seminar series. And we'll, as we know, we'll start quickly with an introduction, but then also we'll have Dr. Hindin leave time at the end for questions and comments, but people should also jump in if there's a question during the interview or during the seminar. She said, please jump in. It's better to bring out things as they're being presented. But also we're setting aside 20 minutes at the end to have discussions. So without further ado, let me introduce Michelle Hindin. Michelle's an internationally known researcher in global women's and adolescent health. She's an adjunct professor in the Department of Population, Family, and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. And she's the former director of reproductive health and its programs at the Population Council. As everyone knows, is a large research, international research NGO. She was a scientist at the World Health Organization at the Department of Reproductive Health and Research, where she led their portfolio on adolescent sexual and reproductive health research. And she's published more than 130 peer-reviewed articles, mentored more than 25 PhD students, and has helped develop global indicators for country-level monitoring of women's, children's, and adolescents' health while she was at the WHO. She received her PhD in sociology from Johns Hopkins and an MHS degree from the Department of Population Dynamics, also at Johns Hopkins School of Public Health. So, sorry, Michelle, is a long introduction, but you have a long career here, and I wanted to do it justice. So welcome, and the floor is yours.
Thank you very much, Rick, and thanks for that introduction. I'm going to go ahead and jump right in. And for those of you anxious about what my title means, you're going to have to wait a couple slides in. So hopefully you'll make it that long. Okay. So just a quick overview of where I'm going with this presentation. I'll give you a brief introduction about me that maybe is a little different than what Rick provided. And then the focus of this presentation is going to be on infertility research. And so a little bit about the context of infertility research and why this matters and why it should matter to all of us. A bit on measurement around infertility, because I think that's one of the challenges in this space. Some recent work that I've been doing on infertility with a sort of deeper dive into one of my recent publications, and sort of a summary of what's next for me in thinking in this space. Just a quick graphical presentation. Rick mentioned the number of peer-reviewed publications I have, and just to give you a sense, I primarily work in low and middle income. Oddly, the two most cited countries in my work are Ghana and the Philippines. And at some point, if you want explanations of how those two countries came to be, I will be happy to. And sort of to summarize my research overall, I use a technique that probably many of you are familiar with, and generated a word cloud with the titles of my publications to kind of give you a sense of the kinds of work that I do. And you'll see that ASRH, which is adolescent sexual and reproductive health, features quite broadly across my research. Contraception, also a big word there, because I've done a lot of work in that space. IPV, which is intimate partner violence. But if you look on the sort of top left quadrant, you'll see infertility in green, suggesting I've done a little bit of work there, but it's not the big feature focus of my work, but it's something that I'm very interested in pursuing further. Why infertility research? I think, we're seeing increasing attention to infertility, the costs of infertility, famous people speaking out about infertility. And I think that that is sort of one of the indications that at least there's some interest in infertility and it's a bit understudied. And you can also see there's some talk about diversity in access to or discussions around infertility, particularly in the US. I think another interesting aspect of infertility is perceived infertility or fear of infertility. And, with the pandemic, we've been seeing a lot more attention to concerns around infertility. Before the pandemic, fear of infertility sort of was related to not using contraception, especially for younger people, and particularly for hormonal methods where their menstrual cycle would change. And so there have been concerns about infertility, particularly in low and middle income countries related to, contraception, which is one of the big areas that I've studied. But then with the advent of the COVID vaccine, we saw both domestically and globally this huge concern about infertility. Things that we saw in the popular press from a very well-known gynecologist being trolled on the internet for saying that, she shouldn't say that COVID vaccines are not related to infertility, concerns that infertility was related to sexual dysfunction were related to the vaccine in men. In fact, recent publications show that COVID actually is related to infertility in men, not the vaccine itself. And then a study from the Kaiser Family Foundation, which showed that parents of 5 to 11-year-olds, 66% who said they didn't want to give the COVID vaccine to their 5 to 11-year-old were concerned about infertility in their kids. And so clearly this has sort of permeated the popular press and language, yet it's a topic that remains very poorly studied. I think another reason to think about infertility is a rights and equity perspective. This has been sort of on the global reproductive health agenda for quite some time. And back in 1994, 179 nations signed on to something called the Program of Action, which was ensuring reproductive rights. And one of the things that's really striking about what was signed on to by these 179 nations, including the US at that time, was that they were talking about, individuals and couples should be able to freely and responsibly decide on the number, spacing, and timing of their children. And what this is translated to in sort of the reproductive health space is access to contraception, sometimes access to abortion. But very few researchers and policymakers have actually thought about what happens when people can't have the number of children they want. What if they can't have any? What if they can't have sort of, they want 3 and they've only had 1? And the reasons that this is important is because we've so focused on trying to limit unwanted childbearing. So it's also become somewhat of a political issue in the reproductive health space. Sorry. And then the last is the title of this talk, which comes from a novel called Stay With Me. And the reason that this is featured as the title and why I put this quote in is because this is one of the things that started getting me thinking about what research is out there on infertility. It's a Nigerian novel, and it talks about this couple trying to have the first child. It sort of touches on historical, cultural issues around childbearing, the stigma around infertility. And if you're interested in the book, I won't reveal it, but there's kind of a surprise ending. But I really think it sort of brought home to me as a sociologist and a demographer, this topic and how it affects individuals, not just populations. Okay. Hopefully now you're convinced that we should look at infertility. So the next question then logically is, how do we define and measure infertility? So it seems like it would be a really easy question to answer, but in fact, it's super complicated and has led to us not actually having very good information on estimates of infertility. So just to give you a flavor of some of these definitions that are out there that are being used to guide the research studies, an epidemiologic definition looks at, it says, it's a disease of the male or female reproductive system. defined by failure to achieve pregnancy after 12 months or more of unprotected sexual intercourse. So the outcome they're looking at is pregnancy, and it's a 12-month period or more, and includes both male and female. Demographic definitions are quite different, and it looks at things like the inability of women who are not using contraception, who are sexually active, to have a live birth. So now we've changed from pregnancy to live birth as the measure. And then the inability of non-contracepting women to have a live birth after 7 years of exposure. So that's sort of like a retrospective measure of infertility. And then another definition that's being used in the demographic space is the absence of a live birth for a woman who desires a child and has been in a union, which is either marriage or less ongoing but less legally binding union for less than 5 years, during which they've not used any contraceptives. And I think one of the things that also strikes me, and based on some of the research I've done in the past, is that, what does it mean to be sexually active? How frequently do you have to be sexually active? What does that look like? And much of my research to date has looked at how and when people use contraceptives and how fraught that space is. And then the final piece that's super complicated here is desire for a child and what that means. Again, it seems like a simple concept, but there is a huge and very rich literature on how poorly we measure that concept as well. So great, it would be great if we could rely on the clinical epidemiologic definition, but we have very few data sources to get to that. So this is sort of expanding a little bit on the previous slide, but just to show how much variation there can be. So in addition to what I've noted on the previous slide, part of our issue is what the measures are. And so a lot of the measures can be self-report, and that has issues, pros and cons. Many people, especially in low and middle income countries, who report that they're having issues around infertility have never been to a doctor, have no idea whether they're actually experiencing infertility. Or it's calculated based on the number of births that somebody has, and that determines whether they've experienced infertility. It could be, as I showed you on the previous slide, the outcome could be pregnancy, the outcome could be birth. Again, we're really bad at measuring pregnancy. Birth is more clear, but again, where are the data for that? And then the denominator has a whole range of possibilities, from people who are trying to get pregnant. It could be all women, it could be lifetime, it could be currently, it could be couples, and then also like, where are the men in all of this, especially because most of the data come from women. And then how long are we looking at to determine whether somebody or a couple is experiencing infertility, so the time horizons can vary substantially. So then when you look at, the next logical question is, what is the prevalence? And please keep in mind all the caveats that I've just shown you on the last two slides. The prevalence is been estimated at about 1 in 4 couples in low and middle income countries are affected by infertility. And that estimate was based on a publication in 2004. So quite a while ago. And then the most recent data we have on sort of population global estimates come from 2012. So again, publication from 20 years ago using data from longer than that. They've estimated that 10% of women who've remained in a stable relationship have tried to become pregnant, were unsuccessful. We don't know about men. WHO also estimates that between 48.5 million couples and 186 million individuals live with infertility. I'm not sure how those numbers align with each other. And we do, based on the way they've estimated and for all the potential error that's in those estimations, the rates haven't really changed much between 1990 and 2000, and we don't have more recent data than that. Okay, so now that I've given you this sort of broad introduction on why infertility might be important to be looking at and sort of my motivations for getting in this space, I'd like to share a little bit of my recent research in infertility. So while I was at the Population Council, I advocated for a sort of special allocation of resources to be looking at infertility as sort of something that we need to be considering from a reproductive health and rights space, and really in an evidence generation space. And so a couple of my colleagues and I published a commentary that basically laid out what I've presented in sort of the rationale for why look at infertility, and it was published in 2020. I assembled a very broad team across many of our country offices of people who said they were interested in working on infertility. And we developed a conceptual framework of how to study infertility in sort of a very public health kind of way. And the first thing that the group was really interested in was looking at the lived experiences, sort of the qualitative nature of infertility, what that looks like, how people go about figuring out they have infertility, what kinds of treatments are available to people. And it primarily focuses on low and middle income countries. The protocol for this was published, and they're pretty far along in the data abstraction, but there are quite a number of studies that are out there that sort of document the lived experiences of infertility. And now I'd like to turn to the recent publication on something that seems like a sort of departure from where I've been, but I was working with a colleague on climate change, and she's really interested in environmental toxins, and we were really interested in endocrine disruptors, and from like both a social science perspective as well as a more epidemiologic one. And so we had been looking at the fact that arsenic exposure has been shown in sort of animal models to be related to reproductive health outcomes. And so we decided to embark on looking at the relationship between arsenic in groundwater and adverse reproductive health outcomes. We found some really cool data in India. And so that's what I'm presenting on. So for those of you who are not familiar, arsenic in groundwater is estimated to impact over 20 million people worldwide. And to note that there is arsenic in drinking water in the United States is one of the countries where there's a fair amount of arsenic in the ground. Arsenic has been shown to have adverse impacts on a range of human organ systems, as well as on the reproductive system. And as I sort of mentioned, we are able to find secondary data to explore the hypothesis of whether groundwater arsenic was associated with adverse reproductive health outcomes in India. So our novel data sources. So the first is, where does the arsenic data come from? And it turns out that there's a group that's been doing sort of monitoring of arsenic, and they've done a machine learning model and looked at data from more than 30 studies to get sort of estimates of arsenic in the groundwater. And this data from India was developed from 2005 to 2018, and it's gridded data, and you can basically aggregate it to the district level to see what the prevalence of estimated arsenic in the groundwater. And then we paired that with a nationally representative district level household and facility survey called I think it's the Demographic Life and Health Survey version 3. It's a large nationally representative data source from over 643,000 women in India. There's self-reported data. It's a very multi-component survey, but one of the reasons we found it and we're really excited about it is it's one of the only nationally representative data sets that has self-reported information on experiencing infertility. And we use these data aggregated to the district level to match alongside the arsenic data. So in terms of just what the questions were and what we looked at in terms of health outcomes, women were asked about their reproductive history, and there were several questions there. If women had ever had a stillbirth, which was defined as a pregnancy ending at greater than 28 weeks. If they experienced repeated they were asked if they had any miscarriages and then how many. And then we developed a variable to look at if they've had 2 or more miscarriages. And then in terms of infertility, they were asked the question, in every place there are couples who want children, but some women do not get pregnant. Did you face such a problem in getting pregnant? And there actually are follow-on questions to the treatments that were sought for that, and whether it was resolved, but that's not part of this publication. And then what we did was, as I mentioned, aggregated the data to the district level. And just to give you a sense, in India, 4.3% of women reported having a stillbirth, 3.3% of women reported that they had recurrent pregnancy loss, so greater than 2 miscarriages, and 8.3% of women reported that they experienced infertility. Okay, so what we did was we did some exploratory analysis. We did ordinary least squares regression modeling. We did diagnostics for spatial autocorrelation. We plotted and mapped local indicators of spatial association maps to identify clusters where you could see arsenic and our outcomes. And then we found, because there was high levels of spatial correlation, we used spatial error models as our final results. Okay, so what did we find? What we found was that for each percentage point increase in the probability that a district's groundwater arsenic levels exceeded 10 micrograms per liter, stillbirth rates were 4.5% higher, rates of repeated pregnancy loss were 4.2% higher, and infertility was 4.4% higher. So statistically significant. Does this explain all of these outcomes? No, but it was very consistent. And we also did adjusted models where we adjusted for age, rural, urban residents, wealth, and educational attainment. And those variables, you could see in each column, the left-hand side is the unadjusted models and the right hand is the adjusted models. And we didn't see substantial change or attenuation except for the infertility outcome. And part of that was explained by higher women who had higher wealth had higher reports of infertility. I noticed that I'm missing my map. I'm really sorry about that. I can try and pull it up during the discussion, but to show you what the mapping looks like in terms of the infertility, repeated pregnancy loss, and stillbirths alongside the arsenic.
Michelle,
yeah.
I saw the map for just a second on the side. Maybe.
Here it is. Thank you.
Yeah.
Thanks, Rick. Okay, so this is the map, and this sort of gives you a visual representation of what this looks like. So on the first gray one is the map of the predicted probability of arsenic. And you can see that in the northern parts of India, it's darker, suggesting higher concentrations of districts with arsenic. The next map over is the average number of stillbirths. And you can see, if you just imagine the arsenic laid on top of that stillbirth map, that there's clearly some spatial aspect to it. Again, and very much so in the northern parts of India, states like Uttar Pradesh and Punjab, you see this sort of higher level. The next map over is more than 2 miscarriages. And again, you see that concentration up north. And then the last one is the infertility. So when we did this mapping, it was pretty clear to us that there was some kind of spatial relationship. Okay. So just in terms of takeaways from this analysis, there are a couple of important limitations to keep in mind. One is that it's an ecological analysis. And so, we're looking at associations, and we're doing fancy spatial analyses, but it's still just associations. And it's at this sort of larger level. Another important limitation is that the data source for arsenic doesn't tell you whether individual households are drinking water that has arsenic in it, or that even in the districts that they're drinking that water. But we know from the context in India that many households are using well water that would leave them exposed to this arsenic. So future studies can probably get to a finer level than we were able to. And then, there are issues around self-reported measures of adverse reproductive health outcomes and reporting bias and social desirability bias. But even with all those limitations up front, I think there's some really important key takeaways here. One, this is one of the first population level explorations of this topic, and with a very large data set. For me, who's so interested in infertility, it's one of the only data sets that provides these kinds of direct questions at a nationally representative level. And I think another real advantage is it combines two novel data sources. And, I have in parentheses, it shows the power of secondary data. I think one of my other sort of passions is that, for many, many years, I've worked and collected data, and we have so much data. And, especially with the pandemic, you start to think about, how much more data do I need to collect? How much more participant burden do I need? And what sources can be used to generate new questions, to confirm, confirm suspected hypotheses. And so this was a really nice example of being able to not leave our households and yet do this kind of work. So to take away from the sort of larger presentation, infertility is common. It potentially impacts 1 in 4 couples globally, and probably impacts a very different number than that if we could only get good estimates. Access to diagnosis, treatment, and care for infertility is a rights-based issue that's received limited policy and donor attention. Globally, treatment is unregulated and very inequitable, and domestically it's also inequitable. And what I hope to do as next steps is I'm currently working on a sort of measurement NIH grant to get better consistent population level estimates using a range of novel data sources and data sources that are commonly used in demographic research. I think there's a lot that can be done to look at other novel and underutilized data sources. And just this morning, I was looking at some of the data sources domestically that are being collected for both arsenic exposure and then other sources for reproductive health outcomes. So I think there's some possibility to do that. And then I really think raising awareness and improving treatment and resource allocation on this really important topic that affects so many is something that I'd like to see happen next, with evidence showing why it's important. And last but not least, I was reading on how to do good presentations, and some people said, if you put questions up and no one has questions, it's really embarrassing. And so one recommendation was to show some photos. So these are 3 different photos of different opportunities where I've been teaching and or giving presentations. So the top one on your left is me in Rwanda, talking about a revision to the national population policy that I worked on with the Ministry of Finance. The one below that is a course that I taught on gender and women's health at Johns Hopkins, and you can see there's only 1 man in the class, so maybe not put gender in the title if I want men to come. And then the last is a course that I taught on adolescent health in Malawi. Thank you very much.
Great. We'll do the applause, both with symbols and reality.
Thank you.
Thanks, Michelle. So let's open it up for questions and comments. I'm looking around and I see Stefan has his hand up and Arnold took his mute off. So Stefan, Arnold, jump in.
Thank you. Okay, thank you, Dr. Hindin. I was pleased to see that you ended your review of your own work with looking at the environment and putting this into your thinking. Along those lines, in your review of what had been done or what was missing in the literature, you've pointed out that the question of male fertility has not been addressed. And since you are talking about the environment, I think there's good evidence that male sperm quality and quantity varies under various conditions of, for example, including air pollution. Yes. Have you considered looking into this going forward?
Yes, and that's a great question. And it's one of the sort of starting points of where my colleague, who was the first author on that paper, and I were. So one of the things that we started looking at was male infertility, because I think, as you rightly point out, there's a lot of literature. Sorry, my cat is walking across the screen. There's a lot of literature and definitely a lot of animal models showing sort of the impact of environmental exposures on sperm quality, sperm motility, and all of that. I think that, for me, in the more public health space, the data are so lacking. And so one is like, how do we get good measures of infertility on men? And what's shocking to me from maybe the gender perspective is like how easy it is to measure infertility in men, yet how often men are not included in any of the demographic work that we're doing. And so I think there's there's so much that needs to be done on men. And I think there is really, very suggestive evidence. But I think, for me as a more population space, like how do we get there without, getting men to give sperm samples to really look at this? And we don't really have nationally representative data on male sperm quality, but I think there's something there. And even in our analysis, we didn't look at men's reports of experiencing infertility. But I think that at least in the data that I didn't present, when women were saying they had a problem with infertility, about half the time it was the man that was the problem. And so we know that that's the case. We just kind of need that next piece, that next investment to get there.
Thank you.
So, yeah, Arnold and then Emily.
Yeah, I see a couple other hands up, but I'll ask really quickly. You mentioned briefly the issue of economic household wealth, income, et cetera. And I'm wondering, in the India study, was it possible to look at any sort of demographic information around, household income, et cetera, across that band? Because it's my understanding that might be an area where there was a little more wealth in parts of it, not others.
Yeah. And I'm sorry, I didn't have the numbers in front of me. So in our adjusted models, the wealthier households had higher reports of infertility, but then none of the other outcomes were related to household wealth. And then the districts with higher levels of educational attainment had lower levels of stillbirth and infertility. And what you do with that, I'm not exactly sure. I think, there's certainly room for refining the analysis and sort of doing a further breakdown. But these kinds of surveys, at least in my experience, don't ask actual income. And so we have these measures of household wealth, which stand as a proxy, for income, but not a great proxy. We also looked at rural urban, and there were no differences, and I was kind of surprised about that as well. And the education was kind of in the opposite direction from what I thought. So I think there is more to unpack in that space. And I think, again, with further analysis and maybe sort of delving into some of the other infertility questions in the data source, we could get a little bit more refinement.
Thank you.
Sure.
Emily, then Margaret.
Thank you for that great talk. I wanted to piggyback on Stefan's question also, because I am also interested in the environment and its impacts on reproduction. So I wanted to ask, you specifically mentioned endocrine disruptors, talked about arsenic specifically, but are there other environmental exposures that you would like to consider or plan to consider in this context?
Yeah, I am not an expert in the environment, and I'm so excited to look at other opportunities and collaborations. And so I would love to talk to people like you about what other sort of variables we think might be available. And I think, one of the things that I've learned through this process, again, is like there are data out there. We don't expect it, but there are data out there, and we just kind of have to pull it together. I think, the thing with arsenic that was really compelling is, there are all these standards of what's safe in the drinking water, but my understanding is there's actually no safe level of arsenic in the drinking water, and it's unbelievably common. And so, I think, for many public health issues, often the one thing is bad. So like, we shouldn't have arsenic in the drinking water here, India, or anywhere else. And that should be enough for us to get rid of it. But it was really interesting to me to see that connection with a topic that I know a whole lot more about.
How about Margaret? You got your hand up?
I do have my hand up. I'm going to take it down though before I start, so I remember. So this is really interesting to me because I came because the subject is infertility, and this actually is my area of expertise. I collaborate with a professor of clinical obstetrics and gynecology at Penn Medical School, who's also my younger sister. So this has been much fun, and we've written 3 books on the subject. So, but I only really know about the United States. And so I wanted to do 2 things. One is I want to offer to kind of comb through a little of some of the sources I didn't use, because this is really interesting to me for a very different reason. It kind of shows how people in one field don't read people in another field, even if they're studying the same subject, because there are anthropologists who study infertility around the globe. I'm an Americanist. We don't really use that work in our work, but there are people like that. So I would like to make one offer. I will look through my notes and see if there are some people that maybe you haven't thought about looking at, who are in social sciences and who study infertility around the globe. And then I'm going to tell you 2 stories. So our most recent book was a history of assisted reproductive technology. We call it The Pursuit of Parenthood from Test Tube Babies to Uterus Transplants. But our first book was a long-term history of infertility, starting in the 17th century and coming up to the 1990s when the book was published. And so there are different ways of measuring infertility, as you said. And I remember beginning to do this work and looking for measurements of how much infertility there was in the late 19th and early 20th century. And I gave it to my sister, the doctor, and she said, but there's no national database here. You can't use this. And I said, I'm a historian, you have what you have. And you say what the limitations are, and you have what you have. And increasingly in this country, there's a national fertility survey. So you do, the CDC has that information on its website. So you do get a consistent sense from about 1965 to the 2000s about the prevalence of infertility and something else that they call impaired fecundity, which also includes miscarriages as well as infertility. And my second story has to do with male infertility. When we were studying male infertility, I read a bunch of anthropologists on this. And it was so interesting. There was a study of couples who had to have donor insemination. This was before they had ICSI, which is a treatment for male infertility that actually can get around male infertility. So you don't need donor insemination if you're lucky. But you would have these couples going to this clinic in England, getting donor insemination. And you would have these men saying, well, I just really don't think of infertility as being my issue. It's my wife's issue. And so the self-understanding was of infertility was less on the part of these men. We do know that of those people who get treated for infertility in this country, about somewhere between 30 and 40% of infertility has male factor involved. But we also have to consider, what about people who are infertile, and they do need help to get pregnant because they don't have sex with men. I mean, they need help to get pregnant. I mean, it's a kind of you might call it cultural infertility or something like that. So I know there is a lot of information about the United States, and the CDC attempted to actually find more. There are huge gaps as well in data, with a national action plan on the study of fertility that they put forward during the Obama administration. But the whole process died during the Trump administration. I don't know if it'll ever be resolved. And one of the things that many of my readers find shocking is the fact that in the United States, we have absolutely no idea how many babies are conceived with donor insemination.
Yeah.
None. Absolutely none, because it's not characterized as assisted reproduction. So we know how many babies are born using donor eggs because that's reported. But we have there are so many things that we just have no idea about, even in the United States. And so this is a really interesting subject, and I will try to see if I can find out some of the people who've written on it globally, or maybe outside of your area, but still in the social sciences, not history.
Right. And just to say that I am pretty aware of much of the work that's being done globally, and didn't put that in my presentation.
Right.
But no. It's just, going down this path of like, what is there out there? I mean, as a sociologist, similar to an anthropologist, like, what is there? So like,
Right.
Deep dives into what's going on. And I think one of the really interesting areas that sort of goes across both global and domestic is sort of the reproductive tourism that's happened in trying to get low cost infertility treatments. And there's a sort of a really interesting and rich space that sort of bridges like what couples in high income countries have to go through to get treatment. Also to say there's some really interesting legislation that's recently passed in New Jersey around ensuring that people can get infertility treatment under their health insurance plans, looking at people who've experienced cancers, but also sort of, as you mentioned, access to treatment for people who don't have an ongoing sexual partner, who have sex with the same sex partners. And so I think there's a lot of going on. And also there's the NHANES survey had some questions, which is a national health survey on infertility that got us some prevalence estimates. How good they are, again, kind of variable. But again, lots and lots to do.
And I'll let other people ask their questions. But in this country, what is so interesting is that the myth is that infertility is a problem of the well-educated and the well-to-do, whereas in reality, when you go down and dig into infertility rates, it is lower income people, it is people with less education who have higher rates of infertility, but the myth is that infertility is a problem of the upper middle classes,
and poor access to treatment too, and services,
and poor access to treatment, because New Jersey is one of only 8 states that has reasonable access to assisted reproduction. Some other states have access, but reasonable access. And I know of people who have moved to New Jersey in the past 20 years because they could get access to reproductive technology here because it's part of the law in New Jersey.
Yeah. Thank you.
Sorry, Michelle. You see, no matter what topic you talk on, we'd have an expert at Rutgers on that topic.
It's fantastic.
We have a lot going on. And I know Edward's expertise. I know his question is going to be very interesting. Let me just jump to Edward.
Okay.
Thank you. So I really, thanks a lot for your presentation. It has me thinking a lot, and particularly in terms of environmental health disparities. And I was wondering if you could comment on other sort of either public health, social inequities, or even psychological correlates that maybe worth investigating or looking at their interaction when it comes to infertility?
Yeah, I mean, there's so much in this space. And I think part of it, as I sort of mentioned quickly in one of my slides, we did sort of this mapping of what like the research questions are and where the gaps are. And I think, it's both in terms of like the predictors, if you will, of infertility, as well as the outcomes. And one of the things and why I sort of mentioned that book is sort of the psychological and emotional components of infertility. And I think, so there's that whole piece. I think, there's a whole big space around secondary infertility, which is, you've had one either pregnancy, birth, depending on which definition you're using, but also the sort of sexually transmitted infections component that plays very substantially into thinking about secondary infertility. There's some relationships too, like around, some of my other work around unsafe abortion and infertility. So there's like a whole huge space. And I think the exciting part of it is this opportunity to really think about this intersectional nature of infertility. So you have both on the predictors and the outcomes, sort of this whole range. And then to me as a demographer, there's all the measurement questions. And so I feel like there's a lot, and I would just say that, I think there's been some more attention to sort of gender preferences in terms and sexual behavior and infertility, but I haven't almost seen anything on people who have disabilities and infertility. And so I feel like that's a really important space, especially in reproductive health in general. Like we're really good about trying to like break down the data into these different groups, but we have so little data and few data sources on people with disabilities. And again, I sort of get back to the rights-based soapbox. Like we're only concerned about limiting children. Why are we not thinking about this topic? So yeah, I mean, there's just so many exciting possibilities.
Thank you. Thank you.
Yeah, so anyone, I had a sort of a continuation of what you and Margaret were talking about, the inequity in treatment in the United States, but also stepping back, what's the magnitude of the problem, I guess, comparatively to other countries and other economic settings. But the problem here in the US probably has varied just like in India or other countries.
Yeah, and so I have a little bit of data. I'm sorry, I'm just looking at my notes because I can't keep all these numbers in my head. So in terms of the prevalence, and as Margaret and I were kind of discussing, there are a couple of different data sources that you can look at, but the estimates kind of vary widely. And again, sort of based on these definitional issues and how the data is collected and who the data are collected from. So there was one estimate from the National Survey of Family Growth, which is a large sort of ongoing study that found that 15.5% of women, and again, we don't know anything about men, are experiencing primary or secondary infertility. And what was really interesting about this, I mean, it's a large data set. They were able to break things down by race and socioeconomic status, and there were really no differences. And so I kind of wonder, are we missing something in the way the question was asked, how people are answering it, or is that inequity not in that space? Another survey called NHANES, which does, again, like multi-purpose, had a question about if they've ever attempted to become pregnant over a period of at least 1 year without becoming pregnant. Now, not a great question, but what they found was that overall 13.8% of women said yes to this. And again, this is lifetime reports of infertility or potential infertility. And that was a little bit high. The highest group was non-Hispanic whites at 15.4%, followed by non-Hispanic Blacks at 12.9%, 10.9% for Hispanics, 10.4% for Asians, and 11.4% for other or multiracial categories. So not as much variation, again, as I would expect. But in terms of the treatment, obviously, there's huge issues in terms of access. There's issues in diagnosis, there's issues in access. So there's differences by educational status. So, people with less than a high school diploma are substantially less likely to get treatment compared to those with, by income as well, and wealth quintiles. And then another stats that I found was that about 40.6% of non-Hispanic Black women and 44% of Mexican-American women sought infertility care, and that's significantly less than 65.3% of Asian women and 79.8% of white women. And so there's where you see the disparities. So it may be less on terms of the actual experience of infertility, more in terms of the access to treatment. And so, yeah, I mean, again, more to be done in this space, but, I think we need sort of the groundswell of people who are interested in the space providing evidence and then saying, hey, like, we need to invest resources. I mean, we will need more states like New Jersey where there have been investments and people are, doing travel tourism to New Jersey or moving to New Jersey to get treatment. I mean, I think that's fantastic, but why is this not sort of in the more national space?
That's
Can
interesting.
I jump in? I mean, I do think that this is, when my sister and I were finishing our last book, we started interviewing people and before Trump was elected, and we interviewed a lot of physicians who were very active in the reproductive medicine space. And the ones we interviewed before Trump was elected, because my sister and I, I'm a historian, she's a physician, but we make a point of saying that healthcare is a human right and that infertility care is a part of healthcare. And so that as a nation, we need to figure out a way to do this. So we would talk to these doctors, many of whom were very socially concerned before Trump was elected. And they would say, oh yes, there should be insurance coverage for infertility care. There should be Medicaid coverage. And then we were continuing on after Trump was elected. And then they were starting to say, oh my God, all of healthcare is under threat. Maybe we should stop worrying about this right this minute because we need to worry about getting basic health care to people. So there seemed to be kind of a lot less interest and less commitment after Trump was elected, and our book came out in 2019. So our last data was from 2018, and we did find, though, I'm going to go back and look at your information, because we did find, looking our data, that there were higher infertility rates among women without a college education than there were among women with a college education. And that there were higher rates among African-American women than there were among white women. And I'm going to have to go back and look at my data source. So it does come from the most recent comes from 2018, but fairly consistent. Since the early 20th century, that the poorer you are, the more health problems you are, and the more likely you are to have health problems that are going to lead to infertility issues. So, so I'm going to have to go back and look at my information to see where I got it, because I can't keep it all in my head either.
Well, and I think too, it may be just how it's been asked, and like the time period, all that stuff that was in that weird slide where I was talking about the numerator and denominator. I think a lot of that matters in terms of what the estimates look like and how big the sample is and all of that.
Right, but
yeah.
it is, but there is a lot of perception, because if you like me immerse yourself in the the image of infertility, and especially of the use of reproductive technology from the 70s, 80s, the 90s, the media is filled with mostly professional women who get married later and then start trying to have children later, and then they have difficulties, and that's more prevalent in the 90s and the 2000s.
Right.
We have three or more epidemiologists on the Zoom call here. I'm sure they can label how the data's gathered differently is going to have different outcomes. It sounds interesting to so hopefully try to maybe have you all keep talking, Margaret and Michelle, about trying to figure out where the biases are to get the different results that you both, or the different impressions that you both just talked about. So we should wrap up. Does any comments here at the end, or I'm looking at folks that didn't say something, or Michelle, do you want to say something to close out this lunch hour?
If there are no other questions, I just want to go back to sort of one piece in the assisted reproductive technology space. And one of my co-authors on the arsenic paper is well, we had two reproductive endocrinologists who were co-authors on that paper, helped us read like the lab model, the animal model data and all of that, because we were really unsure about that space. But one of them is actually a clinician who's out on the West Coast who's developed a device that is like a low cost means of doing sperm insemination. I mean, in terms of like not going to a hospital. And he's primarily developed it for oddly Silicon Valley people who are either in same-sex relationships or others. There's a huge population who want assisted reproductive technology, and this is like a super low-cost option of a way that it's been highly successful. And so I was starting to think about that also in the global space, because the cost to people and the sort of human cost of it is so high that I think there's all this innovation. And I think thinking through like engineering and other disciplines and how we could bring them all to bear in the space of something, again, that I feel like really deserves more attention than it's getting.
That's very interesting. Well, we could hook you up with our biomedical engineer department. They're very keen on global health issues also.
That'd be fantastic.
So thank you all. Amelia, are you? Oh, you're saying good. Congratulations. I thought you had your hand up.
Yes, I am saying congratulations. And I'm a little bit disappointed that she took a book from Nigeria, where I'm from, and then did her study in India instead of Nigeria. But
I have other studies. I was just featuring the India one. And seriously,
this is a very touchy topic in terms of psychological well-being of especially women in the different cultures. So I'm really very impressed. My comment is that there's a lot to uncover.
Yes. Yeah. Well, if you haven't read the book and you're interested in this topic,
I just downloaded the book and I'm going to
fantastic. Okay, then I've done my job.
Thank you.
Great. It's been very rich. Thank you, everyone.
Thank you.
Thanks, Michelle, and appreciate it. We'll applaud again.
Thank you very much. It was really a pleasure to get to know you a little bit.
Thank you.